Right?
Like, why is Frank calling your phone?
You got your parathyroid back there. So look it up right now. Push pause.
We're
Go
good
see.
friends.
Find out
I've known
what it
her
does.
forever.
All right. There's a function for everything. You just can't think about it right now. So, anyways, the thyroid. Thyroid has many functions. It deals with the uptake of the calcium into the bones. It deals with your glucogen levels. It deals with also your blood pressure, stuff like that. So you can't live without the parathyroid.
Right, you can live without the thyroid, but not the parathyroid.
Thyroid, be gone. Parathyroid, please stay. You know what I'm saying?
You'll die without it.
So now we're coming down. This is still the trachea right here. Okay. So we want to end it. We're going to end the trachea at the carina. Okay. We're still in the hyaline cartilage right there. That's the end of the trachea. We're going to come into the primary bronchi. Low respiratory. Okay. When you get to the primary bronchi, you're going to go into each lobe. Each lobe is a lung. Upper superior lobe, middle lobe, inferior lower lobe. You go from the primary into the lobe, you're going to be secondary bronchial. Okay, now one secondary bronchial is going to go in here, one's going to go in here, one's going to go in here. When secondary bronchi go into the lungs, then they disperse into tertiary or segmentary bronchi. And from there, they're going to go even farther. This is all part of the conducting respiratory zone. Okay, the conducting zone of the respiratory system. So when you go from the tertiary, you're going to go to the bronchial, to the bronchioles, to the terminal bronchioles, to the respiratory bronchioles. Now at the terminal bronchioles, the conducting pathway is going to end, and at the respiratory bronchioles, the respiratory is going to begin. Because now you're in the lungs, you got to switch the gases, you know, within the alveolar duct down to the alveolar sac, which is like a group of grapes, to individual alveoli, which is like one single grape. And at that single grape is where it ends, and it turns around, and it goes back, and that's how it happens, okay? Now it goes to the lung. This is the right one. Why is it the right one? 1, 2, 3 lobes.
3 lobes.
Okay? It has more room. More room? That's still lung back there. I'm going to go to the other side. This is the left lobe. Got the 2. I'm sorry, I forgot one thing. You got the horizontal fissure separating the upper superior and the middle lobe. And you got the oblique fissure separating the middle lobe and the inferior lobe or lower lobe. Okay? Here you've got the left lung. It's going to be a little bit smaller. It looks the same size. Still looks big, right? One problem. It's deceiving. It's got a cardiac notch in there. Why do we need a cardiac notch?
To hold the heart.
I could use that extra room, right? No, I got to hold my heart. I do not with it. So anyways, we got 2 lobes. 1 and 2. I don't know if you can see it, but I'll point it out. That is an oblique fissure that's separating the upper lobe from the lower lobe, superior lobe from the inferior lobe. Now, I got 2 lobes to go into, so what does that mean? When you're growing, I have 2 secondary bronchi going in. 1, 2 bronchi are going in there. When they go in, what are they going to do? Of course, they're going to separate the tertiary, secondary. They're going to go on down until you get to the alveoli sac, turn around, go all the way back up. You need to do that? Rewind. So, we're going to turn over the left lung. So this one shows you the best. You get the diaphragm in there, right? Now, obviously, it's up, okay? So that means we're exhaling air. Alright? When it goes down, we're inhaling.
We're inhaling.
You got the spleen right here, right? Why is the spleen? Why do I know the spleen? It's the left side. Where's your spleen?
On your left
side. Simple. Okay? So that's that. Now we're going to move on. Okay. That's the respiratory. We're going into the digestive. Here's your esophagus. Okay? Your trachea ended up here. Your esophagus has to go through what?
The diaphragm.
You're going to go through your diaphragm. You're going to come out the esophageal hiatus. Esophageal hiatus.
That's that little hole right there.
Which has
I'm sorry.
sphincter in it. Once you go out something, you can't go back. Okay? I've already eaten you. You can't come back up my throat. Then I got to vomit. Gross. So I'm going to count. You're going to come out, and I'm going to have a sphincter so you can't go back in. That's called, it's near the cardiac of the stomach, so it's called the cardiac sphincter. It's going to attach there. Here's the okay, that's a region. Cardia, body, pylorus. Okay? Here you've got
Fundus.
the fundus. You can hold it. All these curves, they're still fundus. You got the lesser curvature. There's a curve. You got some nice curves.
Greater curvature.
You can see her greater curvature.
I can't see. Okay.
You can see the greater curvature right there. Okay? One thing about the greater curvature is that it's going to originate one of the mesenteries. The mesentery here is the great omentum. Okay? And we'll go into some deeper detail about what a mesentery is. Basically, it's huge serous, serosa, bifolded like this. Serosa this side, serosa this side. Over here you got the parietal peritoneum, which is that layer right there. Okay? You can't have this organ moving like that up against the parietal peritoneum.
Right.
You've got to have some sort of fluid. Okay?
Retro.
That's why we've got this. These are two bifolds of serosa that are going to have serous membrane on each side. What does serous membrane do? It has serous fluid. Serous fluid is going to allow for a friction-free environment. There is a disease that will cause that happens to where there's no serous fluid and it's excruciating pain. So
Because your organs are sticking to your...
Yeah, they can't just move and groove like they want to. All right, so now I want to teach you about the sublayers. We've got 3 sublayers on the stomach. This one, if you look, going in a line.
Longitudinal.
This is that. We don't have another one past this, so it's not outermost, it's just outer. The outer longitudinal sublayer. Okay? Here, you really saw. This is going to go in circles all the way around. This is in between. This one is in between this one and this one. This is intermediate. Okay? Intermediate circular sublayer. If everyone remembers the oblique, go down like that.
Inner.
So you got the inner, it's on the inside, inner oblique sublayer. Outer longitudinal sublayer, intermediate circular sublayer, and inner oblique sublayer. Okay? Don't forget we've got the lesser curvature, the greater curvature, coming up here to the pylorus. So when we leave the stomach, because we've done everything we need to out of here, we've got juices on it, all that stuff.
Open it up.
So we're going to go in through here. That small intestine at the beginning is too hot, but before we leave, we've got to see what's on the inside. All right. Now the good thing about the stomach is if you're real tall and slender, it can sit like this. If you're short and stocky, it can be like this. Little fun fact. Good to know also. This stomach can hold up to 1 gallon of food. That's 4 liters. So it's going to stretch. And then it's going to come back. What's going to help it do it? This is called the mucosa layer with rugae. R-U-G-A-E. Okay? Mucosa because mucus is inside of the intestine. And all the intestine mucus is in there. It helps with digestion, helps move stuff along. Mucosa layer with rugae. The rugae is going to help it spin and bring it back. All right? So, since we're going to go out, the pylorus, we're going to go through a sphincter. Alright? What do you think it's called? Pyloric sphincter. In that region, you're leaving it, you're not coming back, lock the doors, get out, it's done with you. You're going to go into the small intestine, through the duodenum. Okay? Small intestine, duodenum. Large intestine, small. Duodenum. Okay? Here we have the pancreas. Okay? In the pancreas, we have a main pancreatic duct. It's going to secrete pancreatic juices that are supplied by the Yersinia cells of the tissue. Okay? because the acini cells are exocrine. Okay, within the pancreas you also have islets of Langerhans that are endocrine glands that produce, the alpha cells produce glucagon and the beta cells produce insulin. If you're diabetic, you'll have issues with that. Okay, so the acini cells are going to produce pancreatic juice, which is going to flow into the duodenum. Right? Back here, you've got the common bile duct. Okay? The common bile duct is going to come from the liver. Go through the liver real quick. Here's the falciform ligament. That's another mesentery for you. It's going to hold up against the diaphragm. So it's going to extend from the diaphragm into the mesentery. It's called this.
Look at you.
So you're going to have the right lobe, so the bigger left lobe. This is the brown ligament because it came from the umbilical cord. Okay? This is going to be the ductus venosus.
Yeah. Ligamentum venosus.
Ligamentum venosus, sorry. It's going to be the quadrate lobe. Think of it as 4 quad. Caudate, I think of like a southern woman. Caudate! Caudate lobe. This is going to be your gallbladder. Your gallbladder is going to hold bile. Bile is very important. It helps break stuff down within here, the fat. So it's going to come up through the cystic duct. Okay, the cystic duct is going to merge with the common hepatic duct. They're going to form the common bile duct. What's going to form the common hepatic duct? So that's the right and the left. The right and the left hepatic ducts down here are going to come in to merge to form the common hepatic duct, with the cystic duct merges to form the common bile duct, which secretes bile into the duodenum, around the opening, this is the name on the test, the opening of the hepatopancreatic ampulla in duodenum, okay, in the duodenum, right there. You also have an accessory duct coming off of the main pancreatic duct, but it's not shown on this model. It's going to come in there as well. Okay, so it's going to go in here. Now this right here, number 528, that is, there's a name for that. It's called the duodenal mucosa with plicae circularis. You have to say the whole daggone thing, I know. Sorry. Anyway, going through here, we're going down. It's basically a holding tank. It's getting all the juices, it's getting ready. Coming up here, it's going to be here. You don't have to know that name, but if you wanted to, it's just nice to know. It's duodenum, jejunum junction. Okay. What ligament?
Huh?
What ligament?
On the liver?
Falciform ligament?
She
I
did
did,
that.
mesentery.
She did it.
Oh, I forgot the lobules.
Lobules.
Lobules, right
Yep.
there.
Labio.
Okay. So now, you're coming up, you're going to go into what? See that right there? That's where the junction is. It leaves the duodenum. It comes into the jejunum. Jejunum. So, we got the jejunum here. Big, bad, awesome part of the small intestines where everything takes place. It's where the magic happens, baby. You got your proteins, your enzymes, all that stuff is digested. It's
And
wonderful. And absorbed. You're going to go through here. It's covered by what? The greater omentum, which is a what? A mesentery, which is a what?
Layer of
Bifold of serosa, which is what? Serous membrane that secretes serous fluid that allows for a friction-free environment. Thank you. So, then, this is going to be the small intestine. So it's going to go through all these winding, turning curves, all the way down. You're going to come here. You're at the bottom. 539. 539 is here, and it's here. Okay. We have an opening. This is your ileum. Why is it called ileum? Maybe it's because it's in around the pelvic area where the iliac is and all that stuff. Ilia veins, you remember those? So we're going to sit right there. And that little thing merges with here. Okay? This is where a junction takes place. This is the ileocecal junction. Why is it the ileocecal junction? Ileum, cecum. Ileocecal junction. We can have a junction, that's fine, but we've got to have something to keep it from going back in. At this point, we've got everything we needed from it. It's now become weight. Alright, so we're going to go in through here. What is that bad boy? That's our little finger. That's our door to lock that bad boy out. Done with you.
Ileocecal junction. Ileocecal
Finger. No longer need you. Your weight's out. Your ticket out. You need to go through the colon. to the large intestine. Here's the cecum, ileocecal sphincter. Now we're going to go uptown.
Hey, can I cut you off for a minute? So the reason why it has a sphincter there to close it off is so there's no backflow into the small intestine, because the small intestine is the most sterile part of your intestines. Once it gets into the large intestine, that's where all the dirt and garbage and whatever is. So if it backflows into the small intestine, then it can cause a real big problem. So once it goes through the sphincter, it closes. And so then whatever goes on in there, that's fine, as long as it doesn't backflow into the small intestine.
Go! Woo, go, Chris! Hey, loving it! Strong women. Hey, all right, so now it's on to the ileocecal junction, to the ileocecal sphincter to make sure it doesn't have bad junk stuff. You just so are nice, clean, freshly clean.
Yeah.
I just vacuum tight small intestine, okay? So it comes in here, we're ready for it to get out, throw that trash out the way. It's going to go up a what? Ascending area. It's not descending. Forget, descending goes down, ascending goes up. Right? This right here looks a little weird. Doesn't it look like the regular colon, does it?
No.
That's a muscle. There's like 3 muscles in there. Think of it like a Latin term. Tenai coli. T-E-N-A-I-E. Tenai, and then it's on the colon. So let's shorten that last word to rhyme with the first one. Tenai coli. Tenai coli. That's what it is. Now that doesn't function. What it does is it pushes all these together to get the waste to go up and over and down. Okay? And when it does that, it's going to produce pouches. These pouches are the Haustra pouches. H-A-U-S-T-R-A. Okay? Haustra pouches. So what's going to happen now is we're going to go uptown. We're going to take a right on the right colon flexor. Okay? Right colon flexor, and parentheses, hepatic. Don't know if you have to use that. Check with your professor. Right hepatic flexor. Okay? You're going to come up. Now we need our bad boy. Alright. We took a right on the hepatic flexor. We're going to come up and down across the interstate. Don't forget that's the tenai coli. Okay? We produce that pressure to make the Haustra pouches. Alright. This is your transverse. This is going what way? An anatomical word? Transverse. Alright, the transverse colon, which is right here. Tenai coli, transverse colon. Now, this is suspended and it's moving. It's mobile. It's not retroperitoneal. Retroperitoneal means it's hanging, it's suspended. I mean, it's like attached to the parietal peritoneum right there. This is not. This is on the inside. It's intraperitoneal. Intra. So it's got to be attached to the mesentery to stay in place. The mesentery is going to be, because it's on the transverse colon. Transverse mesocolon. Let's just shorten the last 2 words to make it happen. Transverse mesocolon. Alright, which is all this right here. And it goes to the pancreas. Okay? The pancreas is a retroperitoneal. It is. Once again, these are outlined by visceral peritoneum. That's got the mesentery. What are mesenteries? I'm going to let y'all go with that because I already do it twice. We're going to come over here. We're going to go down the left side. This is going to be the left colic flexure. It's also parentheses and splenic. Don't worry about that. Left colic flexure. Ask the professor. Don't listen to me. Double check you don't have to use splenic. Left colic flexure or splenic flexure. We're going to go down. You're descending. We're going downtown. We want to go outside. Okay? We're going down. We want to go outside. Make sure you got your stuff ready. Don't want to hear nobody yelling. Everybody, we're going down. Don't forget that's the tenai coli. These are the Haustra pouches. Descending colon. We're going to come down. We're going to take an S curve on the sigmoid rectum. Yep.
Take it out.
Yep. We got the S curve on the sigmoid rectum. Okay. Remember, this is hanging there. So what do we got attached to it to keep it in place? A mesentery. Since this is near the sigmoid, let's just call it the sigmoid mesocolon. Okay, let's do it. Now it is. This is sigmoid mesocolon. Okay? This is going to be around the intestine. They're hanging there. We got to have a mesentery. Intestinal mesentery. Okay? It's not attached to a colon, so we don't have to call it a mesocolon. Okay? Alright? This is an intestinal mesentery. So, we've come down back to where we were. We're getting ready. We're coming close. You know, we're coming close to the border, so we want to make sure we got our passports and all that stuff ready. I want to go to Tijuana, y'all, okay? Okay? I want to see this dog stuff. So we're coming down here. We're going around the sigmoid colon. We're coming into the rectum. Something happens in the rectum. In the rectum, your tissue changes. It goes from simple columnar and all the main parts up here to stratified squamous. Why? Okay.
Oh,
Yeah,
sorry.
no, it's okay. Because up here, you've got stratified squamous as well. You're dealing with, up here you've got pseudostratified ciliated columnar epithelium because you're dealing with air, you're ciliated, you want to have the bacteria, all that stuff so it doesn't get down into your lungs and stuff like that. Here, you've got, starting at the oral there, you've got stratified squamous because you have big stuff coming in there. You want to make sure that it's okay, that it's not going to get hurt, you know, you want to have extra protection. You have the stratified squamous, okay? It's going to end right here.
At the trachea.
Okay. Right here at the, at the trachea, I'm sorry. No, it's going to end right here at the esophageal hiatus. Okay, because now you're going to have juices.
I'm sorry, my thing, I got it away from stuff.
Pause.
Go. Oh,
You want to pause?
I don't know how to keep those.
We're taking a break. I hope y'all got something to drink right now. Ready?
Okay.
All right. Now, here is where the stratified squamous is going to end, and the simple columnar is going to begin within here.
Okay.
Because we have pushing, pulling, pushing, pulling. We need that extra space for the stuff to happen, so it's going to be a soft tissue. When you get down to the rectum, this stuff is it's ready to come out now. So it's a little bit harder, stuff like that. More rough. So we're going to come down here to the rectum. All right, we're in stratified squamous. Boys and girls, we have 2 boundaries to get through before we get to go out tonight. 2 boundaries. So we're going to go through them. We're going to go into the anus, the anal region. Before we go out, and if your passport's ready, we got to go through one guy. Man, he's the internal anal sphincter. Got through him. One more test. External anal sphincter. Boys, we're home good. We're going out. Now, this is the anal. Okay? One more thing I want to say is that if you have stuff in here, if you have diarrhea, what has happened is that it has not had enough time to go through the large intestine to get all the water out. Okay? If you have constipation, it means it's sat in there too long and the large intestine absorbed up way too much water and it's stuck. Drink water. That's it. And watch what you eat.
Ladies and gentlemen, Crystal.
Thank you. Oh, one more thing. I thought I grabbed it. I don't know if I did this little Berman right here. Vermiform appendix. Okay? That's your appendix. Not necessarily needed. Contains, like if you do a flush or whatever, of your bacteria, this is going to hold the normal flora down there so you can repopulate it later on. Now, Crystal was saying the reason to have this as well, for an infection that can happen, is that for some reason, the reason for the sphincter here is so that it doesn't go down, the bacteria that's coming up here doesn't go down into the appendix and infect or, get all ingested in that good normal flora and cause an infection.
Which would cause it to be inflamed, and that's where you end up with a swollen appendix. When you get the pain, that's when you have to get it removed because it's infected, because the sphincter didn't work, and so you had some backflow, and it went into your appendix, which has normal flora in it.
And that's about one more thing. I showed you earlier, but you didn't really get to see it. That is the common bile duct. Okay, just making sure you know. I think that should do it, except for the glands. I'm sorry. You have your sublingual salivary glands. You have your submandibular salivary glands. You have your submandibular duct. Okay. Over here. I like to think of this because we have the carotid right here. This is the parotid gland, the parotid salivary gland, which has a parotid duct going to it.
This is 5 times. Okay.
Okay? And that's it.
And then the suprarenal, right?
Oh, the suprarenal, that's right.
Adrenal. And what are they supplied by? Where do they get their blood supply from? The suprarenal
They get their blood supply from the suprarenal artery.
Yeah.
All right. Good luck.